Perfect. Welcome and good afternoon. First, I want to thank you all for joining us today for our session titled Navigating Healthcare Access, Exploring Multiple Avenues to Address Challenges in Access and Barriers to Care. I do want to take an opportunity to highlight this slide. This is the first webinar being hosted by that newly refreshed Kansas Health Opportunities Coalition. As you know, KFMC has had the Health Equity Group for a couple of years now, but we did kind of refresh and repurpose the mission and vision of that coalition. So I just wanted to take a moment to mention that while KFMC is still managing the coalition and will house the resources on our resource hub, it was very important that we move forward as one whole coalition. So we do have a new logo that you will see on these slides, and we would like you to start associating that logo with our group. I also wanted to take a moment to note that if you are interested in being at the table with us, we still have some seats. So you can reach out to any of the partners on today's call, or you could email myself, and we'd be happy to get you involved in this group. My name is Brenda Groves, and I serve as the quality improvement manager at KFMC Health Improvement Partners. I am very pleased today to serve as your host and facilitator. This session is being recorded and will soon be available for viewing on the KFMC Health Equity Resource Hub, and along with the handouts and the recording for today. Handouts for today's session were emailed to all registered participants this morning by Miss Loretta. As always, thank you, Loretta, for your support. Sometimes those emails do not go through or they're blocked by IT. So if you did not receive those handouts, please check the chat during the webinar, as we will drop links to that in chat. As we're speaking of chat, we do want you guys to become familiar with chat. Initially, we would like you to go ahead and type in your name, your facility or clinic, your city, along with your role. If there's multiple people from your organization attending today, if you would give credit to everybody who is actually in the room, that would be great. This will give you an opportunity to test out the chat, as that's how we're going to do Q&A today, as well as it will help us to ensure that we have captured proper attendance for today's session. I also wanted to take, as the people are typing into chat, I just wanted to take an opportunity to highlight the 2025 Kansas Health Impact Conference, Bridging Gaps for a Healthier Kansas. We have a really, really exciting lineup this year. And so if you have not had an opportunity to check out the lineup or register, we highly encourage you to take time to do so. You can go to the next slide, Loretta. Our agenda for today will include a short welcome and intro, an overview of healthcare access issues in Kansas, followed by a review of programs and resources that you may find helpful as you address these issues within your own communities. We will ensure we save time at the end for questions. It is my honor to introduce our additional speakers today. Again, my name is Brenda Groves, and I serve at KFMC. I will be passing the second part of today's presentation to Miss Jill. Jill is the Director of Education and Communications at the Kansas Healthcare Collaborative, and she has been at KHC for the past 9 years. Jill has more than 25 years experience in healthcare, and she has a very particular interest in addressing the issues of our rural patients and providers. Celia Ruiz is the project coordinator and mental health first aid instructor with United Healthcare Community Plan of Kansas. She has been with United Healthcare for 13 years and has been in the managed care for over 25 years. Celia is also a trained medical interpreter, a QPR instructor, and a NAMI certified facilitator, and a health advisor for communities concerned for immigrants and refugees. Thank you, ladies, for all of you do, and I'm honored to present alongside you today. Go to the next slide. Access to healthcare is one of the most critical factors in the overall health and well-being of Kansans. Yet across our state, access looks very different depending on where you live, what your income is, or the resources that are available to you within your own community. Many communities continue to face workforce shortages, financial pressures, as well as geographic barriers that make it difficult for them to get timely and appropriate care. At the same time, Kansas, though, is home to very innovative models of care. We have very strong community partnerships, and we have dedicated healthcare providers who are working tirelessly every day to help try to close those gaps. This webinar is not intended to be a one-size-fits-all education to cover all healthcare needs of all of our Kansans. However, there are multiple sources of funding, organizational supports, social and medical supports to address the varying healthcare access needs of Kansans. We would be remiss if we didn't acknowledge that we are all living in very uncertain times. Not only are regulations and funding in a constant state of change and uncertainty, but things just, there's misinformation, right? Things aren't matching. So currently, to the best of our knowledge, as of today, this information is correct. Again, it is likely to change. So we encourage you to explore these avenues as you're connecting with individuals and families throughout your journey of connecting and look at their specific needs. Right. So we're going to start today with just the basic uninsured versus underinsured. So the term uninsured means not having any healthcare coverage at all. So this includes your private insurance, Medicare, Medicaid, CHIP, military, or any other government or state programs that are out there for folks. People may be uninsured for several reasons. One, they may not realize they're eligible. Or they're just not eligible for a program. They may have lost coverage due to life changes, or they may be at risk for losing their coverage soon and unsure of what's coming next. Or for some folks, they may simply just not see the value in having coverage. Being uninsured creates a barrier to access because patients are often unable to access that preventative care, their medications, or any specialty services. And so as a result, treatment is delayed or treatment could go, the person could go without care entirely. On the other hand, the term underinsured means the person does have some sort of coverage, but it does not provide full protection for them. So they remain financially vulnerable. So like high deductibles, co-pays, and then extremely limited benefits. So being underinsured also is a barrier to access because even with insurance, patients may avoid seeking necessary services due to cost, leading to delayed diagnosis, poor health outcomes, ultimately just trying to avoid medical debt. I'm gonna go to the next slide. When we look at access to health insurance and resources, one of the biggest barriers is just the wide variety of eligibility requirements. Eligibility is truly not a one size fits all. And so therefore it can depend on factors like age, residence, income, assets, health conditions, veteran status, as well as immigration status. Beyond meeting requirements, people also face barriers in just the application process itself. It's very cumbersome. It can be very complicated, sometimes requiring multiple applications, which can be especially hard for those with limited health literacy or limited digital literacy or digital access. Another barrier I wanted to highlight here is just documentation. When applying, people are often asked to provide certain levels of ID, proof of address, and proof of income. Yet for some folks, they lack access to those documents, or their proof of income doesn't meet certain verification standards. There's mismatched dates, missing names, or incomplete tax records. Even after applying for benefits or for coverage, some folks are facing multiple denials or having to go through appeals, which create, again, delays and discourage overall follow-up. And then legislation and funding changes also can shift the rules very quickly, leaving families unsure about their eligibility and overall coverage status. You go to the next slide. Payer issues. For both Medicare and Medicaid, many providers have limited or closed panels, meaning they aren't accepting new patients within their practice. So this just on its own restricts access even when somebody does have their coverage. We're seeing this a lot with our dental providers. They're facing very similar challenges with limited Medicaid as well as commercial provider networks, leaving many patients without local options. In addition to the person piece of it, the providers themselves are struggling with the rising cost of just doing business. Those costs are often not fully reimbursed by are not covered by reimbursement, which makes it difficult for providers to stay in network or sometimes to even stay open. Patients then face the challenges of managing their overall cost of their care, balancing premiums, deductibles, meds, and out-of-pocket expenses. Finally, the shift towards value-based care, which emphasizes quality outcomes instead of volume, brings both opportunities as well as challenges, especially for our small and our rural providers who may lack the resources to fully participate within those programs. As I mentioned, the out-of-pocket cost. So out-of-pocket cost remains one of the biggest barriers for accessing care. Deductibles, the co-payments, and co-insurance all add up very quickly, creating that financial burden. That financial burden tends to discourage patients from seeking necessary services. Many families, especially today, are finding themselves having to choose between paying for medical care or covering everyday expenses like food, housing, and transportation. The impact of these financial barriers is very serious. Again, patients can delay or forego their care altogether, and we know what the negative outcomes of that. They may not be able to see the provider they trust or need, which again is very, very important when we're talking about healthcare, is making sure that you have that trusted provider. Their conditions that could have been managed early are now more severe, which have more impact to the person as well as being more costly over time. And then, of course, again, families are facing increased risk of medical debt and financial instability. So out-of-pocket costs may not create, it can create immediate financial strain, but it also widens the health disparities because when care becomes unaffordable, patients are left without the preventative routine and specialty services that are essential for long-term health and overall well-being. One of the most important parts of equitable care is effective communication. Effective communication ensures understanding, empowers our patients, and ultimately improves quality of care. Yet for many patients, language access remains one of the biggest barriers to access. When individuals cannot clearly express their needs, describe their symptoms, or understand their instructions, they risk misdiagnosis, they risk poor adherence to treatment, and preventable complications increase. Limited English proficiency often leads to delays in seeking care, which requires higher rates of emergency department use and lower participation in preventative services. It can also lead patients to feeling excluded, misunderstood, or mistrustful of the healthcare system. We can go to the next slide. Transportation, again, is also one of the most persistent and overlooked barriers to healthcare. More than 1 in 5 adults across the United States have limited public transit access, and therefore they are foregoing needed health care simply because they cannot physically get to the provider. The issue is even more pronounced in our rural areas like Kansas, where distance, cost, and infrastructure challenges create daily obstacles for individuals and their families. For many, the problem is distance. Rising fuel prices and the increasing cost of vehicles, insurance, and just basic maintenance make driving those longer distance less affordable. Transportation barriers don't just create an inconvenience, but they do directly affect health outcomes. When they're missing appointments, they're delaying preventative screenings, or they go without the critical treatments altogether, we are going to have those negative outcomes. In emergencies, the inability to reach care quickly can have life-threatening consequences. And then families with young children are also facing additional challenges right now while arranging transportation, but even for mental and behavioral disorders. They find themselves traveling long distances to be able to access that level of service for their child, but then they also then have to look at how transportation affects that. We can go to the next slide. Stigma and bias remain powerful barriers as well to accessing healthcare, as it shapes how people are perceived, how they're treated, and how they're supported within the system. Stereotypes and prejudices, whether based on race, ethnicity, age, gender, or disability, can lead to discrimination that undermines trust and discourages individuals from seeking care. The effects of stigma and discrimination are not just social, and they can be deeply, deeply harmful to someone's health. Individuals who are experiencing stigma are often reported to have reduced hope, reduced lower self-esteem, and worsening psychiatric symptoms. In healthcare specifically, stigma can reduce the likelihood of patients staying engaged in their treatment due to fear of being judged or misunderstood. We can go to the next slide. Health literacy is critical, but it's also, again, something that we tend to overlook. It refers to the degree to which the individuals have the capacity and the ability to find, understand, and use health information and services to the best of their ability to make informed decisions for themselves and their families. When our patients and our families are struggling to navigate medical terms, complex instructions, or unfamiliar systems, they are less likely to follow that treatment plan, access the preventative service, or manage chronic conditions effectively. You can go to the next slide. I quickly mentioned earlier digital literacy, but digital literacy is an increasingly essential piece of modern healthcare, but it is a significant barrier for many of the people that we serve as well. So as our healthcare systems are expanding their digital services, we tend to overlook training of the patients on how to navigate those tools. So there's a lot of our people out there who are expected to navigate without adequate support. Many individuals need education on just basic computer use, such as logging in, navigating the websites, as well as downloading applications. Some may struggle to access their patient portals where they're expected to receive the test results, review provider messages, and or just simply request prescription refills. When digital literacy gaps go unaddressed, patients risk become disconnected from their care, which again delays services, could contribute to missing critical updates, critical appointments, and overall decline in care. Go to the next slide. So as I close us out, truly, the complexity of the US healthcare system is in and of itself a significant barrier to care. There's a lack of coordination across providers and systems, which further compounds the problem. And when when you take all of those things in together, such as, even digital literacy, that can leave patients having to repeat their medical history multiple times, tracking down their own records between facilities, taking the right records to the right doctor. It's a lot for our patients to navigate through. So these barriers directly can affect their health outcomes as well. So confusion and frustration are contributors that lead to delayed care, missed appointments, and overall just avoidance of the healthcare system altogether. Simplifying the healthcare experience will be essential for us to ensuring that we have equitable access. And this is going to include improving care coordination across our providers, making insurance processes more transparent, patient navigators, community health workers, and just designing systems that prioritize clarity and patient-centered communication. So by reducing complexity, healthcare can become more accessible, timely, and effective for all. So thank you for your time today. At this time, I am going to pass over to Jill, and she is going to lead the conversation for us on some programs and resources across Kansas.
Thanks, Brenda.
Thank you, Jill.
So let's be real. Brenda was, if nothing, accurate when she said our system is complex. And if we had a whole day for this webinar instead of an hour, we still probably would only scratch the surface of the issues that we're facing for access today. So, we don't intend to address every single issue and solve all the issues in the previous section, but we hope this section provides some helpful resources and programs that we have used in our current and previous roles, and that we hope that if you're not already familiar with, that you can familiarize yourself with or your staff with to help address some of the issues that we're seeing in access here in Kansas. Next slide. So we wanted to start in our Medicaid section. It's pretty lengthy, but one of the things we wanted to start with is truths in Medicaid eligibility. So we're seeing a lot of misconceptions in the media and in politics about eligibility for Medicaid nationwide. So let's talk about what the truths really are. So just as a broad spectrum, in Kansas, if you are under the age of 19, over the age of 65, pregnant, blind, disabled, or have achieved SSI disability status, you can be eligible for Medicaid. And there are a few other disease-related statuses or conditions that can help a patient qualify for Medicaid. But really beyond that, those are the main truths in Medicaid eligibility in Kansas. We're going to talk about some other scenarios beyond that. But if you are not under the age of 19, over the age of 65, pregnant, blind, or disabled, or have the medical conditions we're going to talk about in the next section, more than likely, those patients are not getting Medicaid in the United States. Next slide, please. And just to note, in the slides, anything that looks like a hyperlink that's in blue, that's underlined, those should work in your slides, and those will be the resources that you can click on. And so, especially in our Medicaid section, there's a lot of links, and there's really cool information that you might want to go learn more about. So, to delve more into eligibility. So in Kansas, the beneficiary must live in Kansas. So we've been hearing a lot in the news and a lot in media about citizenship and undocumented citizens, undocumented immigrants in Kansas. And there's, or in just nationwide, and there's this misconception that an undocumented immigrant can cross the border and fill out an application for Medicaid and immediately become a Medicaid beneficiary. And that isn't really, for the most part, an untruth. Undocumented citizens are not eligible, for the most part, for Medicaid, with the exception of SOBRA and for some asylum and some of those refugee and asylum programs. So they have to go through a verification process for citizenship and identity requirements, just like any other citizen that's applying for Medicaid. So some immigrants must wait 5 years before they can get coverage. And so what does that mean? What we're really talking about is immigrants who are lawfully present in Kansas, who have a green card, for example, have to wait 5 years before they can get coverage. And I actually did a little bit of research on this because I find it interesting, because it has been politicized so much. According to the Kaiser Family Foundation, and I wrote this down because I wanted to bring this up, eligible non-citizen immigrants represent 6% of Medicaid enrollees nationwide. So this is not a large population that's receiving Medicaid in the United States. And this benefit not only allows that population to receive care after that 5 years, but it allows our providers to be paid for services they're providing. So it's, it's an important benefit. So then just beyond that, Medicaid's typically always the last insurance billed, and they do backdate coverage. So oftentimes when we're applying, if we're helping someone apply, or when a beneficiary is applying, there's a place to indicate whether they have unpaid medical bills, and they can pay up to 90 days of unpaid medical bills. So that's a really important factor to not miss in those applications, especially if we're helping them, because that can help reduce that burden of unpaid medical bills. And then I know Brenda talked about how things are rapidly changing and there's some uncertainty in things, but right now, medical assistant is currently reviewed annually. Now that is subject to new federal regulations, but those are not in place. So right now it is still reviewed annually. Next slide. So we're going to talk about a number of different programs, but each one of these programs has different income rules. There's not just one size fits all. The programs look at both earned and unearned income. And then programs in particular that for elderly and persons with disabilities do look at resources and assets. And we've provided some examples of those on this slide. Next slide. So in the next several slides, we're going to look at a lot of different fee-for-service, in particular fee-for-service programs. So just of note, when we talk about fee-for-service Medicaid programs, we're talking about programs that are not part of MCO programs. These are programs where the state of Kansas pays the provider directly, and it's not going through Sunflower or United. And each one of those has different benefits, different eligibilities. And then we'll have a few slides that talk about some different terms and programs. And then in particular, some of those can be a little bit confusing. And so we're going to cover a few of those terms and programs. Next slide. So first of all, one of those terms that's a little bit confusing. I think they said early on that I've been in healthcare for over 25 years, and spin down still can be a little bit confusing for me at times. So essentially, spin down is sort of like a deductible for Medicaid beneficiaries. So, we can't just say what that spin down amount is for Medicaid because it's different for every person and or family. But essentially, spin down comes into play when a family or a beneficiary is over the maximum allowed income and or resources for that Medicaid program that they've applied for or that they are eligible for. And so essentially that spin down amount, that out of pocket, has to be paid by the patient before Medicaid will begin kicking in and starting to pay claims. So it can be confusing because when we check eligibility in the organization, and it shows that they're eligible, but then later when the claim comes through, we might get a claim that says that there will be no payment due to a spin down amount. But again, once that spin down amount has been exhausted, then Medicaid will begin to pay those claims. Next slide. So SOBRA. So we talked earlier about how our undocumented citizens are not eligible for Medicaid, but this is an exception. So SOBRA is what we call that, it's really emergency coverage, temporary emergency Medicaid coverage. For the most part, at least what we see it used for in Kansas is really 48-hour emergency labor and delivery coverage. So the SOBRA program is only available for patients who don't meet the citizenship and the Medicaid citizenship rules. It's used for retroactive coverage because it's emergency coverage. It's not something that you can anticipate that emergency ahead of time. So typically, it's a program where our patients are applying for that after the emergency has occurred. So in the case of labor and delivery, best practice would be that we have folks in the hospital that are helping families with that application. Again, best practice would be that we have interpreter services to help with folks who have a limited English proficiency in helping with those applications. Sometimes maybe if maybe that doesn't happen in the hospital and we're seeing that patient in the clinic and we know that there's a situation where we're a community health worker and we're trying to help with maybe a debt that's been incurred, it's still a great opportunity for us to help them apply afterwards to help alleviate that debt and get that service paid for. So another fact from the Kaiser Family Foundation that I looked up this morning was the SOBRA program accounts for 1% of Medicaid spending nationwide. So another misconception is that this program is widely used and it drains the Medicaid coffers. And really that's not the case. It's a program that allows people to get emergency care when they most need it. And it allows our hospitals and medical doctors that are providing these services to be paid, and that's important. Next slide. So Medican is a program that is specifically for patients with disabilities who have not yet qualified for Medicaid. So it's a limited service program. And again, it provides coverage while we're waiting for those disability benefits. And so if you haven't worked with beneficiaries and patients on obtaining Social Security disability benefits, it can be a very extensive process. It can be a heartbreaking process. Folks are generally never approved on their first application. They're typically almost always denied. Oftentimes, unfortunately, in our system, it's pretty hard to get an approval without an attorney, and it can take a long time to get approval. So this program, folks can receive benefits for up to 12 months, which is wonderful. Sometimes that's not enough, but it certainly is a time that allows them to receive care, hopefully, in that time frame while they're getting that Social Security disability determination. And they do have to meet income and resource guidelines to be eligible for that program. Next slide. So the PACE program is one that some folks may not be familiar with, and some of that is because it's only available in a few counties in central and northeastern Kansas, but that program does provide all-inclusive care for the elderly. And folks that are in that program, both the facilities and the patients, essentially it's a program that provides long-term care through a managed care network. And the requirements for patients in that program is, 55 and older, they must have a need for that nursing home level of care, and they have to be able to live safely in that community with that PACE level of support. So not so sick that they couldn't live in that level of community, needing hospitalization, etc. Next slide. So, a lot of my career, when I think of MSP, I think of Medicare Secondary Plan, but in this case, we're talking about Medicare Savings Plan. But essentially, these are programs where Medicare, or excuse me, or Medicaid may pay the Medicare deductible and coinsurance. So, I know when I look at this chart for years, I'm very familiar with the QMB. We've probably, those of us that have worked in healthcare for a long time, have seen QMB eligibility on Medicaid cards. But there's also the LMB, so low-income Medicare beneficiaries, and then the ELMB, expanded low-income Medicare beneficiaries. And each of those have different income limits that you can see on these charts, both for single individuals and married couples. And then, what part of the Medicare Part A, B, and D premiums, copays, deductibles, and coinsurance differs for each one of those programs. So you may see different numbers of beneficiaries in your practices or in your hospitals that qualify for each of those different programs. Next slide. So this one was a little bit new to me in preparing for this presentation. I think at times we forget that we still have populations of patients in our state that are living with tuberculosis. But the state does have a Medicaid fee-for-service program that specifically is for patients living with tuberculosis. So for these Medicaid beneficiaries, Medicaid provides case management and limited medical coverage. So it's not like some of the other programs where they have, a full host of Medicaid coverage. That coverage is specifically limited to inpatient hospital care and necessary alternative community-based care. And that has to be pre-approved by KDHE. So all the other things like, outpatient medical visits, prescriptions, etc., are not covered under that plan. So pretty limited program. Next slide. And then for our patients who are living with HIV and AIDS, and there's a AIDS drug assistance program called ADAP. We know that the prescription drugs for patients living with HIV and AIDS are so incredibly expensive. And this program pays only for the prescription drugs that are needed for the treatment of HIV and AIDS and related to that illness. So again, this is another fee-for-service program where the state pays the provider directly. Most of the time, it's probably going to be our pharmacies, but again, our inpatient facilities, maybe even skilled nursing facilities, if they are obtaining medications, they can be billing for those medications to this program. And next slide. So presumptive eligibility is a Medicaid program that is really has a much lower uptake than we'd like to see in Kansas, and not really sure why that is. I know we did at KHC, we did an education on this last year, and there were so many people who still don't know that presumptive eligibility exists, and we'd love to change that. So essentially, this is a program that if your facility, if your clinic, if your agency becomes what's considered a qualified entity, you then can help patients. You essentially plug their information into a form online, and that form helps your patients receive immediate temporary eligibility, essentially an eligibility determination that allows you to help them achieve temporary Medicaid coverage. And so over the years when I've worked with patients, you see patients who have a pending Medicaid application, and a lot of things can happen for them. And they can be asked to be private pay, to have to pay out of pocket for their services, and that can create quite a financial hardship. So this allows patients to receive services while that application's in process, and it allows providers to be paid while that application's in process, and they are paid regardless of the decision, of that final decision. Next slide. So Medicaid now also pays for doula coverage. So again, they provide that emotional, physical, and informational support before, during, and after childbirth. They're advocates for patients and families. And those services are paid for from conception through 12 months postpartum. So that began in 2024. That's still current. And if you provide those services, we want to make sure that you're paid for those. Next slide. So Medicare. Eligibility for Medicare, I think most of us know that, when you turn 65, you can go on Medicare, but you can actually, that application happens, you can begin that Medicare application about 3 months before the 65th birthday. But also patients who are on SSI, so if they obtain that SSI disability, they still have to wait 24 months after the disability determination, but also patients who have a diagnosis of end-stage renal disease or ALS can also be on Medicare. And then I think most people are probably familiar with Part A and Part B. Part C, Medicare Advantage plans, we're going to talk about that on the next slide, as well as Part D for drug coverage. Next slide. So we talk about Medicare Advantage plans. For some patients, Medicare Advantage plans, Part C is Medicare replacement plans, and we call it that because they do replace Part A, Part B, and the supplement, also referred to as Medigap. But then, and sometimes that's also Part D for the drug plan. So for some of our, in particular, our low-income patients that maybe couldn't traditionally afford a supplement, Medicare replacement plans can be initially lower cost premiums, lower cost copays, But we caution that there can sometimes be some unexpected risks and costs associated with those plans. And we've shown some of these in these charts. Here in Kansas, sometimes those networks can be limited. And so we may have a patient who signs up for a Medicare Advantage plan, but then finds that the network is limited and maybe their primary care provider or their specialty provider is not in the network, or even sometimes their hospital. And then the drive to the next nearest provider and or hospital that is in that network can create a hardship, both financially and, as we know, transportation is an issue for a lot of folks. And those can create issues that are just, for some people, insurmountable. And then administratively, there some Medicare Advantage plans require referrals, prior authorizations, and approvals that are not seen with traditional plans. And those can, be quite an administrative burden for medical providers, but also can be confusing for beneficiaries to deal with. So mainly we just say investigate wisely and make sure that patients are signing up for plans that truly will allow them to see the providers that they currently see or may need to see in the future. And then also just to note, there is a D-SNP program in Kansas that for those patients that Medicare Advantage plans are the best option. They may qualify for programs to where the Medicaid and state Medicaid may pay some of those out-of-pocket costs. Next slide. We'd already submitted our final slides, and then last week, on the 4th, the Trump administration released new information about expanded access to catastrophic plans. So essentially beginning November 1st on healthcare.gov, folks who previously wouldn't have qualified for premium assistance on healthcare.gov can apply for a hardship that will allow people who are greater than 250% of the federal poverty guideline to get premium assistance. There's not a lot of detail on how this is all going to work, but essentially, supposedly that will be made available to people on and off of the exchange. And so just of note, if you're not familiar with catastrophic plans generally have high deductible and coinsurance, but they still provide the same Affordable Care Plan benefits. So they're a great option for people to have basic coverage. Next slide. And then VA, we have a lot of veterans in our state who don't live near a VA facility. So those folks can receive treatment in the community, and their guidelines as to when that can occur. Next slide. So just the Trump administration has taken away the requirement for secondary approval. And that's supposed to be able to reduce some of the barriers to care and barriers to payment. But just keep in mind that they still have to work with their VA team to get those referrals to seek care in the community. So can't stress that enough. Next slide. And I'm going to turn it over to Celia.
Okay, all right. And I love seeing that we're having folks stick around. That means that all of this is clicking. So thank you for staying connected. So now we'll kind of shift into a different spot where it's been coverage up until now. Who's paying for these appointments? Whether it's an insurance or a program, then Medicaid and fee for service. I want us to kind of switch our minds now into let's say, what if someone isn't eligible for Medicaid? What if someone isn't eligible for these programs, is not a veteran? What are some other places that folks can go to with or without that coverage? Places like community mental health centers, or now certified community behavioral health clinics, are these facilities that will treat for substance and mental health services. These clinics will see folks no matter income, no matter place of residence. It will, though, however, determine which which clinic they go to, depending on which county, because that's the way they're kind of structured. So I'm thinking like Southeast Kansas, it might be like the Ford County, or if it's Wyandotte, it might be Paces. So we have about like 15 minutes left. We're going to leave some time for question and answers. So if I go through these a little bit quickly, just remember that you have access to all of these slides and all of these links. So if you can click onto this next one. with the community mental or the community behavioral health clinics, because I'm still getting used to not saying community mental health centers, they are required to provide these services that you see listed here. Anything from crisis services, where it's 24 hours a day, 7 days a week, something has happened. I'm with a person that needs mental health or substance use support. I don't know where to start. I need some help now. You can call your local CCBHC and they can find at least the immediate crisis support, and then move on to outpatient mental health and substance use services, or other types of services that they have there. When we're thinking of the community behavioral health clinics, there's an equivalent when it comes to our physical health, and those are going to be the FQHCs and RHCs, or federally qualified health centers, rural health centers. These clinics or facilities, they provide the physical health, whether it's going to be and they also have some mental health services that they are depending on the services available, the funding, dental, physical, immunizations, patient navigators, CHWs, community health workers that can help navigate which type of service or which type of facilities folks can find. They have sliding fee schedules. So no matter place of residence, no matter income, they can find, the idea is to have this accessible. So we can click onto the next one. There are also health departments. So health departments, thinking beyond those typical things we may think of, whether it's immunization, sometimes that's the first thing we think of, depending on, the relationship we have with our local health department. That's not the only thing they're doing. They may also have oral health, wellness. They may partner with schools to provide some services for the schools. WIC, many times you'll find it at your health departments. So women, infants, and children, and that's going to be nutrition, education, and food supports, nutrition supports for the baby, little ones up to the age of 5. Or if they have still like weight concerns, they can kind of extend that. Family planning, reproductive health. And then that number 1 where it says environmental home safety programs, thinking about lead. Sometimes it could also be weatherization, or it's going to look different in different counties, but just to keep those in mind. Next slide. Then early detection works. So for cervical and breast cancer, those that are in risk of or have been diagnosed, there are some services that are available. So diagnosis, the health education, referrals, screenings. If you click onto the next slide, we'll see these are the income guidelines that you'll see. So left-hand side where it says those who are at risk, women who are at risk, 21 to 64 for cervical cancer. Those at risk between 40 to 64 for breast cancer must not have health insurance, and their income must be within these income guidelines. Next slide. Telehealth. Looking on the left side of your page, you're going to see some challenges. So yes, telehealth is available. So it's being able to connect with a professional, just like we're connected here. Awesome. I'm going to talk about the benefits in just a moment. But we understand that there are some challenges and things that we've already heard earlier, from that digital literacy, health literacy. Number 2 there where it says payment policy. So how that changes. The access to cellular and broadband, depending on where you're at in the state, and even within a nice large city, there still might be some, towers and types of issues that don't guarantee that same type of access to that internet that other places of the state would. Access to the devices themselves. Being able to do this on a cell phone may look completely different than if we're doing it here on a computer. So yes, we recognize the challenges, but if you look at the right-hand side, when we are able to address those challenges in whatever ways we can, and we're being creative, the benefits that we have to accessing telehealth is that it removes that geographical barrier. It can reduce the behavioral health stigma, because I don't have to actually leave my house. I'm doing it here in the privacy of my home. They didn't see my car parked in front of the house or in front of the clinic, etc. It improves outcomes because we're able to increase that access, satisfaction, being able to do this from home or from a remote place. That individual satisfaction for that individual will be able to do that. Engagement, increased engagement. There is no drive time. I don't have to account for extra time. Maybe I'm not asking for extra time off of work. So it can increase that access there. Next slide, please. Something else to think of. So charity care is the language that we may be most familiar with, but hospital financial assistance. And so then let's say someone is seen in the emergency room or is seen for inpatient care, not insured, no insurance, or the hospital is out of network, not having the access to that coverage to pay for that appointment. The hospitals can provide financial assistance through this type of policy. And so then when you look there at number 2, federal law requires that nonprofit hospitals, which is 58% of community hospitals, provide this financial assistance. The challenge that happens here is that sometimes individuals won't send in the information that the hospital is asking for. So Celia, you've been inpatient, unable to pay. If you need to make any payment arrangements, please contact blank phone number. And oops, that's sitting on my counter. I forgot to reach out to them. The time has passed. It's past 30 days. It's past 60 days. And or maybe I did send in something, but we talked earlier about challenges to documentation. Maybe I didn't send in the right type of proof of income. It didn't have the right dates, or etc. So it is available. It can be available, but just keeping in mind that there can also be some challenges to accessing that. Next slide, please. Indian Health Services. So this is a part of when we go back into history and we see that there was a treaty between the government and federally recognized tribes. There was an agreement to say we will provide healthcare. So what does that look like now in this day is that there are Indian Health Services clinics. On the bottom right-hand side, you'll see those clinics listed that we have here in the state of Kansas. Haskell, so Haskell's going to be in Lawrence, Kickapoo, Northeast, White Cloud, Northeast, Prairie Band is going to be a little bit north of Topeka, and a little bit north of Topeka. And so there still are eligibility requirements, and those requirements to access those services are determined by the tribe itself. So just clicking onto those links, that's an option. All right, next slide. Another program, Kansas Statewide Farm Worker Health Program. So for those individuals that are working in migrant farm work, and on that webpage that you see on the bottom left-hand side, it gives a list there of what is considered farm work, what is considered migrant. But through this program, individuals that are eligible have access to healthcare and healthcare services. And what it looks like is that through this program here, they work with the migrant farm workers, provide vouchers that can then be used at clinics like the federally qualified health centers, or whether it be the health department or an individual provider. It's an arrangement that the farm worker health program is able to work out with that provider. Some of the services that are covered, you'll see on the right-hand side: immunizations, vision, dental, physical exams, behavioral health, substance use, just to name a couple. Next slide, please. Something else that we sometimes don't think about, the employee assistance programs. So employee assistance programs are programs that are provided by an employer at their own choice and at the level of coverage that they want or can provide. And I like to mention this one a lot to our community members, because sometimes we would be surprised if there's a retail provider, a retail employer, and I know this, they provide up to 20 appointments for mental health coverage for the individual and their family. And so then let's say someone is not eligible for Medicaid, does not have insurance, is not able to get insurance through their employer. But sometimes if we look in that manual, that employee handbook, or that onboarding page or website or courses that they give us, and of different ages. I think of our young people as well, those 17, 18, 16-year-olds that are now working. What if they have access to something outside of that medical coverage? All right, if we can click on to the next one. All right, Can Quit. So Can Quit is available statewide for those wanting to address, for those wanting to quit smoking. Sorry, you have a little hair here. And when you look here on the right-hand side, Coaching and goal tracker, those are two things that are available to everyone. And those are available via text messages, email support, coaching. Those are available for everyone. The medication piece, which is very attractive, is not available to everyone, but if they qualify, that is something that they can also receive. You can click onto the next slide. So, in closing, before we get to our last couple of slides, I'll say this. This is a lot of information. We don't expect you to memorize all of this. We don't expect you to be an expert on everything. But when you see on the left-hand side, it says, if you've seen one community, you've seen one community. We do not expect all of this to apply for everyone. This may not work everywhere, but every community is individual, and we have amazing resources in communities that may be the area agency on the AAAs. So the SHIC counselors, and that stands for Senior Health Insurance Counselors of Kansas. These were available at no cost. They're neutral, no commissions. That may be our best bet in community to help navigate which one of these services. What do I look like? What is best for my patient? Maybe it's looking at patient navigators, community health workers. We mentioned that there's some available at the federally qualified health centers, community-based organizations, financial counselors, and sometimes even the commission brokers might be the best bet for your community because they know the community. So I will stop right there and move on to the next slide as we welcome back Brenda, and I believe we're going to be ready for some question and answers.
Yep,
Thank you.
ma'am. Thank you, ladies. So I've been watching chat and I don't see any current questions in chat, but I did want to open it up. We do still have 4 minutes left. So if anybody on today's call has any questions, you can feel free to unmute yourself and ask those questions directly. Or if you would like to ask a question privately, you can send that to myself or Loretta, as well as Jill or Celia. Okay, well, I see we have no questions at this time. So on behalf of your entire Kansas Health Opportunities Coalition team, we thank you again for joining us today. Please be sure to complete the post-webinar survey after completion of the webinar. Your feedback is extremely important to us. As a reminder, the recording along with handouts will be posted on the KFMC website in the Health Equity Resource Hub following today's presentation. And with that, again, thank you.
Brenda, did you see the comment from Elaine?
I'm seeing that right now, yes. K-State Extension offices are in each Kansas county, and Extension also provides SHIC as well as health education for their communities. So there is a link there. So if anybody wants to follow up with Elaine, she has provided that information in the chat for you all to access. It's great information.
Thanks, Elaine.
Yes. And I see there's still a few of you still on the call, so we're just going to kind of hang out in case anybody has anything that you're wanting to talk to us about privately. Hang out for just we have 1 more minute until the end of session. I think we're right at 1 o'clock. Loretta, if you want to go ahead and end us, that would be great. Again, thank you everyone for attending today.